And so I certainly know that this is probably fits more in the practical realm than the emerging realm of this talk. But I do think, especially now in this era of highly targeted and effective salvage therapies, that this regimen is just as relevant, or perhaps more so, while we're waiting for the upfront studies to be completed. And so based on that, I'd like to discuss some of the historical context and mechanism of action of the high-dose steroid regimens. I will, because some of the studies are a few years old already, I'll just quickly go through the high-dose steroid rituximab trials, some recent ofatumumab and high-dose steroid trials, and then talk about some of the ongoing and upcoming clinical trial studies with high-dose steroids. So this is a curve from one of Jan Berger's recent review articles. It's something we've seen many times in this conference, the typical redistributive lymphocytosis. But if you look carefully at the very bottom, that patient actually didn't get ibrutinib or idelalisib, he actually got prednisone. And that patient wasn't treated in 2012, he was treated in 1960. So, I guess nothing really is new under the sun. I think people have been using steroids to treat CLL for some time. And from the beginning, people have noticed that steroids induce both a temporary improvement in spleen and lymph node sizes and at, I guess, more physiologic doses, temporary increases in lymphocyte counts as well. In the following decades, unlike the development and adoption in ALL and NHL regimens, prednisone was found not to be effective in CLL, both as a single agent or in combination with chemotherapy. But at high doses, defined as more than 200 milligrams per meter squared of methylprednisolone, it was found to have modest activity, a series of clinical trials showing overall response rates between 40 and even up to 80%, but with generally short progression-free survivals in the 6 to 8 month range. Briefly on the mechanism of action, I think even after about 60 years, I think the mechanism by which steroids induce the apoptosis of malignant lymphocytes is still not completely worked out, but one of the main pathways seems to be induction of transcription of BIM, which then liberates BAX and BAC from BCL2. So in some ways, steroids are also the first BH3 mimetic or BCL2 inhibitor. There are several other mechanisms of actions as well, but at least in vitro studies with CLL cells have shown that the induction of BIM correlates with cytotoxicity in vitro, and also that this effect seems to also correlate with high expression of ZAP70. Although I don't think we've seen that correlate with clinical outcomes yet. Initial studies looking at the combination of rituximab and high doses of decadron have shown synergistic cell killing, synergistic inhibition of proliferation. And these studies also suggested that the high dose of steroids did not inhibit CDC or ADCC induced by rituximab. So based on that rationale, our group and others have performed a series of clinical trials looking at the combination of high-dose steroids and rituximab. In brief, the first study was done by Januario Castro at UCSD. It was a small study with just 14 patients, all of whom met criteria for being fludarabine refractory. Despite their clinical fludarabine refractoriness, few of them had the FISH characteristics that we characterize with high-risk disease. 2 had deletion 11q and 1 had deletion 17p. The regimen that was initially used was 1 gram of high-dose 1 gram per meter squared of high-dose of methylprednisolone for 5 days, and rituximab in a very dose-intense manner, 375 milligrams per meter squared, days 1, 3, 5, 8, 17, and 22 for the first cycle, and then weekly for cycles 2 and 3. This was given for a maximum of 3 cycles with mandatory infectious prophylaxis. The results were astounding, 93% overall response rate, so 13 out of 14 patients met criteria for response, including 36% meeting criteria for a complete response. And the progression-free survival is 15 months, which I think is still respectable even now for this group of patients. AEs in this trial were not horrible. Like, there was 1 grade 3 pneumonia. There were a number of cases of grade 3 cytopenias, but all resolved before the next dose was due, and so there were no treatment delays due to cytopenias. This was predominantly thrombocytopenia and neutropenia, and a 43% rate of grade 2 fluid retention. Concurrently with this, the Mayo Clinic looked at their experience with patients treated with high-dose steroid regimens and rituximab. This was a case series, so there was some heterogeneity of the regimen received, but most patients received weekly rituximab. They had 37 patients, more of whom would be considered high risk based on cytogenetic characteristics, including 33% with deletion 17p and 22% deletion 11q. And 2 of the patients had also developed Richter's transformation prior to treatment. Their results were consistent with the results published earlier, or with the prospective trial, including a 78% overall response rate, a 22% CR rate, and a 12-month progression-free survival. But more infectious complications were seen, including 29% of patients who were only able to complete the first month of treatment, or not even able to complete the first month of treatment. There was some speculation that infection prophylaxis may not have been as uniform as the initial trial, but certainly these patients were at higher risk also. More recently, or I guess concurrently, another trial was done, also small in size, 14 patients, but with similar results, a 93% overall response rate. This study was a little bit different in that the rituximab dose was given just once monthly, but the treatment was more prolonged for up to 6 cycles. In this study, they also, despite mandated prophylaxis, had very high rates of infections, including 6 deaths due to infections that included both fungal and viral and bacterial sepsis. Based on those initial results at UCSD, we also looked at this in the frontline setting. This was a single-center, 28-patient study. For this study, the dose of steroids was actually reduced by 40% to 1 gram per meter square for just 3 days. And the rituximab was given in 1 of 3 different doses, 375 milligrams per meter squared weekly, or intensified to 750 milligrams per meter squared for 3 days to coincide with the steroids, or 750 milligrams per meter squared weekly for the first cycle, and then days 1, 2, and 3 for subsequent cycles. Again, infectious prophylaxis was mandated, and some patients were given the option of receiving alemtuzumab if they still had MRD positive, if they still had MRD at the end of the HDMP rituximab treatment. The basic results were similar with the relapse refractory setting, response rates in the 90% range, and for this group of patients, a progression-free survival of 30 months. It should be noted that, I guess, consistent with most upfront studies, the rate of 17p deletion was lower, only 4% in this group of patients. Despite the different rituximab doses, there was a suggestion that patients that achieved higher rituximab levels responded better, but that didn't necessarily correlate with the dose of rituximab given or the manner in which it was given. Although some of the PK studies show that giving it upfront in the first 3 days achieved therapeutic doses more quickly. Adverse events are shown here just to emphasize that, again, they were not significant. A few cases of pneumonia, neutropenia, but really not as bad as compared to some of the earlier studies. The authors speculated that perhaps the absence of severe infections was attributed to the dose reduction of the steroids, the restriction of only 3 months of treatment as opposed to up to 6 months, the improved performance status and immune status of patients in the frontline setting, the use of standard prophylactic antimicrobials, and the administration of IVIG for some of the patients who developed hypogammaglobulinemia and infections. It was noted that on average IgG, IgA, and IgM levels decreased for all patients, but did tend to normalize at about the 1-year point. And so based on that, we have continued using this regimen fairly routinely at UCSD, mostly for patients for whom trials are not available or patients with high-risk disease such as 17p, or patients like the ones from Oregon that just do not want cytotoxic chemotherapy. We've adopted the regimen to kind of fit between the 2 trials that we've done. We use, partly for patient convenience, but also to improve the PK. We give both the HDMP and the rituximab at the start of each cycle. The first cycle has a 100 milligram rituximab loading dose. We started using 500 milligrams per meter squared of rituximab based partly on the German CLL studies that they use in the bendamustine studies. except for patients that have very low tumor burden. We just think it helps better with the pharmacokinetics in the tumor sink. We typically use Septra, acyclovir, and fluconazole or an equivalent medication until 2 months after completion of therapy. We build sub-Q insulin to our order sets, and furosemide for edema or weight gain are given routinely. So moving on, studies have been done more recently based on the same principles using ofatumumab. We presented our results at last year's ASCO looking at the combination of ofatumumab and high-dose methylprednisolone. We used a regimen of ofatumumab 300 milligrams for a loading dose followed by 12 weekly doses of 1,000 milligrams, which is different than their standard dose. HDMP was given for the first 3 days of each month at 1,000 milligrams per meter squared. We treated 21 patients. These were all previously treated patients, 24% of whom were considered fludarabine refractory. 19% of them had deletion 17p, and 10% deletion 11q. The overall response rate was 81%. Only one patient achieved a complete response, which was MRD negative. There were 2 nodular partial responses, and the vast majority of patients had partial responses. The progression-free survival with this regimen was about 9 months, and probably due to small sample sizes with those adverse cytogenetic characteristics, we did not see a significant difference between progression-free survival in patients with or without adverse cytogenetic characteristics, although there was certainly a trend towards it. Adverse events were again minimal. Hyperglycemia was the main thing that we saw as far as grade 3 or grade 4 AE. There were some cases of pneumonia, influenza, even one myocardial infarction. I think those all occurred in the same patient. Recently also the Czech group has looked at ofatumumab and dexamethasone. I think used a regimen that was a little bit more intense as far as the ofatumumab dosing, 2,000 milligrams basically weekly for up to 6 cycles. And they used a dose of oral dexamethasone, 40 milligrams days 1 through 4 and 15 through 18 of each cycle. They mandated similar prophylactic medications. Their patient population would be considered higher risk. Their median SIR score was 7. The majority of patients had unmutated IGVH genes. 19% had deletion 11q, and 25% had either deletion 17p or mutated p53. Their trial was designed to give therapy for up to 6 cycles, and that was the median number of cycles delivered. Although 9 patients had to stop therapy early due to infections or even one case of uncontrolled diabetes. Their overall grade 3 or 4 infection rate was 25%. The overall responses were somewhat similar to ours, though probably reflected their higher risk patient population with a 69% overall response rate, 16% CRs, including 1 MRD negative response, and a progression-free survival, median PFS of 10 months. So I think based on this, I think we continue to look at high-dose methylprednisolone-based studies. The ongoing things right now that I am aware of are looking at ofatumumab with HDMP, followed by ofatumumab and alemtuzumab, specifically for deletion 17p. Jennifer Brown is performing that study at Dana-Farber, and is currently accruing both relapse refractory and previously untreated cohorts. At UCSD, we're shortly going to be opening a study combining obinutuzumab and HDMP, and we'll also look at both relapse refractory and previously untreated cohorts. So I think in summary, I'd like to say that the HDMP-based regimens have both in vitro and clinical activity in the setting of high-risk fludarabine refractory and deletion 17p patients. Although the sample sizes of each of the studies have been small, especially the number of patients in these studies with deletion 17p, I think the consistent activity we've seen across many studies is convincing of efficacy. Immune suppression has been problematic in some studies, but I think one could make the conclusion that studies that mandate prophylaxis, minimize the steroid dose, and minimize the duration of therapy have had manageable infectious toxicity, and perhaps that's one explanation for the discrepancy between infectious rates that's been reported. And so I think overall feeling right now is that patients who are inappropriate for chemotherapy or cytotoxic chemotherapy or genotoxic chemotherapy, HDMP-based regimens are both clinically and ethically and financially reasonable. And I think even or perhaps especially in this era where there are very effective and tolerable salvage regimens that patients can turn to if they need them down the road. Certainly patients are more motivated now than ever to avoid standard chemotherapy agents. So I think this is one thing that we can offer and offer safely in the absence of clinical trials.